Parker. Appreciate it. Everybody who's here, thanks for joining us. I think we'll have a medium crowd tonight since it's NCAA tournament time. So, but what we'll do is we'll get through these slides, and that'll take maybe 20, 30 minutes or so, and then we'll open up for questions, and I will answer as many as superhumanly possible. I have nothing else going on the rest of the night for once. So, all right. We're going to talk mostly about erectile dysfunction. We'll throw in some Peyronie's. We'll throw in a little low testosterone as well, and then we'll answer any kind of questions you guys have. So let's go to the next slide. Sorry, we didn't get on this quick enough for me to do it through my computer, so Parker's in control. So if you need any more information, you can look at edcure.org, or you can text edcure to 73771. You can hover over that code that's on your screen right now and get a little bit more information if you'd like to. The reading materials are endless on these subjects. As Parker said, I'm Bryan, Kansas. I've been in Austin it's my 17th year of practice now. I went to LSU, went to Tulane for grad school, LSU Shreveport for med school. I did my residency 1 year at Wake Forest, 1 year at 5 years at Temple. I do a whole lot of prosthetics. I do a lot of reconstruction, buried penis, low testosterone, Peyronie's, a whole lot of men's health stuff. So next slide. So we'll talk about ED. What is it? Inability to achieve or maintain an erection that's firm enough for intercourse. Pretty common. A good solid 20% or more will experience ED in their lifetime, and as age goes, it goes up. Normally, if I see a guy who's 60 years old, and if somebody asks me what's his chance of having ED, I'll tell them good 40 or 50%. By 39 million guys in America have ED of different levels. Next slide. What happens? So basically all that an erection is more blood flow in than blood flow out. As you can see with these pictures, the arteries, the red, dilate, starts to fill. What that does is it helps to compress the veins on the sides. We have some muscular contraction with that as well. So we need more flow in than out equals erection. Too little inflow is an arterial insufficiency. Too much outflow is what we call venous leak. Next slide. A lot of causes of this can be vascular, either arterial or venous, can be from diabetes, high blood pressure, certainly pelvic surgery like prostate cancer treatment or rectal cancer treatment. Also, sometimes we'll see people that have ED as a first sign of their diabetes or their heart disease. So I'll always talk to people about their flows. And if I find a youngish guy that's got pretty impressive arterial insufficiency on a penile Doppler ultrasound, I'll often send that gentleman to a cardiologist, knowing that if he's clogging up the tiny little arteries that are feeding the penis, that eventually he's going to clog up the slightly larger arteries that are feeding the heart. So next slide. Diabetes, not good. 15 million or so people in the US have diabetes. Statistically, 60% of the United States is obese, over a BMI of 30, and 30% is morbidly obese, which is a BMI over 40. So honestly, in my opinion, one of the biggest health problems in the United States is obesity and diabetes. It's incredible how many people I see that have diabetes. Diabetes can affect the vasculature. It can also affect the nerves. The nerves are important to release nitric oxide, which helps to dilate the arteries. So super common in guys with diabetes. So reasons that diabetes causes this, again, 60 to 70% will have neuropathy, and that affects the nerves that dilate the arteries. It does damage inner lining of small arteries, and so they don't dilate as well. ED pills like Viagra and Cialis are dependent on intact nerves and arteries in order for them to work. So if the nerves are damaged from diabetes or, again, pelvic surgery, pills aren't going to work. Pills will work for maybe about 50% of people, which is a good number for a starting point. Next. Other reasons: age, diabetes, bad diabetes control, vascular disease on top of that, again, blood pressure medications, especially diuretics. If I've got a guy that comes to me and he tells me he's had a 3-vessel heart bypass for blockages, I can guarantee you his tiny little penile arteries are occluded as well. How about heart disease? Heart disease can develop within 2 or 3 years of ED. So this takes me back to my discussion a little while ago about, youngish guys starting with ED, and then it might be a precursor to their coming up heart disease. Again, the severity of ED can be correlated with the extent of coronary artery disease. And again, ED can be the canary in the coal mine for coronary artery disease in upwards of 70% of cases. So it's something that I have to look out for. And oftentimes they'll see a cardiologist and they're fine. And I tell them, just see your cardiologist once a year because something is probably going to develop. I mean, it's probably going to develop for all of us if we live long enough. We're all going to develop heart disease if we live long enough. But anyway, next. This is kind of a slide on what I tell patients in the office. We talk about blockage of arteries. Penile arteries are about 1 millimeter. Coronary arteries are about 3 to 4 millimeters. And I tell people that carotid arteries are 5 to 6 millimeters. So we're concerned about clogging heart arteries, heart attack, carotid artery stroke, but penile arteries are very tiny compared to those. So that's that slide. What can reduce our risk of erectile dysfunction? Diet, weight loss, exercise, physical activity. Smoking damages arteries as well. Also, stress levels can be a negative factor as well. But basically, just taking care of yourself in a healthy way reduces risk of ED. Next one. ED and low testosterone. So oftentimes I'll have patients that come in and they come for low testosterone. They don't mention any type of ED even when asked, and they come back, 6 months later, I check labs on them, their testosterone's fantastic. And they say, I feel great, but it doesn't work. And I'm like, what do you mean it doesn't work? And they're like, oh, my erections. And I'm like, yeah, but you told me your erections were fine. Well, I kind of bent the truth a little bit. So they're related, but they're not completely intertwined. Low T happens with age. Very common, a guy who's, 50 years old, 35, 40% chance he has low testosterone. Symptoms of low testosterone are fatigue, lack of desire for sex, loss of muscle mass, weaker erections, lack of morning erections, and sometimes mild depression. Low T is also more common with obesity, people with asthma, COPD, other health issues commonly also result or can be found in conjunction with low testosterone. Next. Options for testosterone: topicals, gels or creams, patches, which is another topical. There are some oral medications. I'm not real huge fans of them. They don't work so awesome, and they're pretty expensive. Injections of testosterone, which are typically weekly, done by the patients, or testosterone pellets, which we put slow release testosterone pellets into the fatty part of your butt about once every 3.5 or 4 months. They work well. None of them are outrageously expensive. I typically, if I'm going to go with a topical, I go with a cream because they tend to be a lot less expensive. Gels, the commercially available gels, are pretty expensive. So I always try to keep patient expense in mind. Let's see, ED and prostate cancer. Pretty common. Nerves that you can see the neurovascular bundle underneath the prostate. That is what actually signals the blood vessels to relax, open up, give flow in. Those can often be damaged or completely removed during a radical prostatectomy. The ED rate post-radical prostatectomy is a solid 35 to 40%. So it's pretty high. And I tell patients if they're going to have their prostate removed, it certainly is not going to improve their erections by any means. So most common reason in my practice for an implant is a guy that's post-prostatectomy. 60% of my implants are from post-prostatectomy ED. The other 40% are diabetics or older or whatever. Next. This slide, similar to what I just said, I always quote 35 to 40%, even with nerve sparing. I tell the story that when I was a resident, I took out over 100 prostates, and I would do the surgery, and I would do the most beautiful nerve sparing ever, and the bladder, neck, and all this, and I'd put it back together, and it was, we barely lost any blood, and it was the best case I've ever done, and the guy can't get an erection to save his life. And then the next one I'd do was a disaster. It looked like a bomb went off in the guy's pelvis. We lost 3 liters of blood, and it was a disaster. And I walk in the next morning to see the guy, and he has an erection with his catheter in. And I'm like, I can't explain that. It just doesn't make any sense. Radiation alone, 10 to 15% ED rate, so lower rates of that. We see a lot of patients that will have high grade aggressive disease, and they end up getting radiation after their prostate is removed. And those guys have, upwards of a 50 or 60% chance of ED post-radical prostatectomy and radiation. Next slide. ED and Peyronie's, very intertwined. What's Peyronie's? This is scar tissue that develops. It's typically from a minor injury during intercourse. Most patients do not recall injuring themselves. It can be from micro trauma. So I always tell patients that this could be a trip to Cabo with your wife, and you guys are there for 5 days and have sex 13 times, and you get on the plane the next day and your wiener's pretty sore, and about 2 months later it's curving. And that's really what it is. You can normally feel these little plaques. They're typically only about 1 centimeter or so. And the issue is that as the penis tries to expand, that scar tissue holds part of the penis back and doesn't allow full expansion, and therefore the curve. A lot of treatment options. Oral agents like vitamin E and Patabit don't work very much. Topical creams are pretty useless. Verapamil injections are good for painful plaques or very minor curves. Xiaflex is used a lot for curvature. It's done in cycles. Average improvement with Xiaflex is about 50 or 60%. I do a lot of plications, basically just fixing the straightness, going opposite the curve and placing sutures to hold it in a normal position. Excising the plaque and putting a graft in is an option for some people if they've got very severe disease. Also placing an implant with or without a plication to straighten it for a guy who has a significant curve, but barely anything works for his ED. Well, he's an implant and possibly a plication as well. So a lot of options for Peyronie's disease. Oh, and that's Peyronie's is pretty common. About 12% of the population or so has Peyronie's. That's what we know about. I think it's probably closer to 20 or 25%, because there's a lot of very minor Peyronie's that's out there, and patients don't seek advice or help with little 15-degree curves. Next, let's see. AUA reports that these can be considered investigational. Shockwave therapy, which we do offer. I like to do penile Doppler ultrasounds to see if the patient is a candidate. That only helps to unclog, dilate, and create new arterioles, so it doesn't do anything for the venous side. So if I find a gentleman with a significant venous leak component on his penile Doppler ultrasound, I will talk him out of shock waves. Stem cell therapy has some promise. It's pretty taxing, though. The stem cells actually have to be done with a bone marrow, can't be done with like a fat extraction. That's very experimental, but actually shows some promise. I don't think that platelet-rich plasma does anything, also known as the P shot. The theory behind it is great, how it would heal. The problem is you're injecting it into what amounts to a blood vessel. The erectile tissue of the penis is a blood vessel, and that platelet-rich plasma is washed away in 2 minutes. So it doesn't have time to do it. PRP actually works great in joint spaces for ortho, but when you put it in a joint space, it's there for 2 or 3 days, able to do its work. So it's my thoughts on PRP. Next slide. Options for ED, oral medications like Viagra and Cialis. Shockwave therapy, like we talked about, we offer injections of Trimix, vacuum pumps, where you put a pump over the penis, suck the blood in, you put a ring at the base. About 30% of people will love their vacuum pumps and use them forever. The other 70% will have them in the recycle bin within about 60 days. Urethral suppositories like Muse, they work reasonably well, maybe about 40 or 50% of people. A little uncomfortable, pretty expensive for Muse. company used to sample that really well. And so I used to have a lot more patients on Muse, but to ask a patient to drop $300 on 6 Muse tablets for an experiment is a little heavy. And then of course there's penile implants. You know, I always like to take people through trials of everything. And once they've kind of exhausted everything that's conservative, that's when we get real serious about an implant. Next slide. How do they work? Pills, basically, these work on the axis of the nerve, blood vessel, or nerve arterial synapse. There is a factor released from the nerves called nitric oxide. There will not be a test on this at the end, don't worry. A compound called phosphodiesterase 5 breaks down the nitric oxide very quickly, like milliseconds. And it's always released and reabsorbed. These drugs actually slow the breakdown of nitric oxide at that nerve synapse. So there's a pileup of nitric oxide. And so that will allow arterial dilation and erectile quality. Work for 60% or so of guys. The absorption can be slowed by food. We see some headache, we see some flushing, we see some heartburn, we see a little low backache with these. This is always kind of the first step, okay? Next slide. How does it work as far as injections? Basically, we're going to inject a compound of 3 arterial vasodilators directly into the erectile body. Tiny little needle, a little insulin needle. This actually works for about 85% of people. About 40% of guys will drop out. About 60% will use this for a reasonably long time. At any given time, I've got 100 or 200 guys that do self-injection. I always teach patients to vary the site. Please don't put it in the same spot. It will develop scar tissue, which will result in curvature. Main reasons for discontinuation: they don't like the injections, it hurts too much, they don't work, etc. If the patient has failed trimix, that's when we talk seriously about a implant. Okay, next. Vacuum pump creates a vacuum, sucks the blood in. You can see there's a ring that goes to the base. Satisfaction rates, you know, like I said, I always tell people about 30% of people love these. Downsides are it's a little uncomfortable, a little bit of bruising. Sometimes the ring is uncomfortable. When you ejaculate, nothing comes out because it's squeezed off by the ring. And most guys that stop using these, they just can't get it to work. You know, they just can't keep the erection that they want to have. I always tell people, please make sure you take the ring off within 20 minutes. You know, at the bottom, you can see 86% of people, so that's even higher than my 70% of post-prostatectomy patients move away from the vacuum devices. So next, Muse or urethral suppositories. You know, these are done similar to trimix, you know, 10 or 20 minutes before. Like I said, success rates of this are about 40 or 50%. A little bit of irritation in the urethra, sometimes a little bleeding from a little trauma, can lower your blood pressure, can cause a little bit of vaginal irritation. Main reasons for discontinuation are discomfort and it's not working well. Go from there. Higher rate of dropout with this post-prostatectomy, you know, it's about 75% or so. And again, I don't do a ton of Muse anymore because I don't have a real good way to get a reasonably cost-effective sampling to patients anymore. So I'll talk about these things. If patients really want to try it, I can prescribe it for them, see how they like it. Next. Implants. So basically there's 3 components. There are the 2 cylinders that go into the penis. There's a pump that's in the scrotum and a reservoir that holds about 2 ounces or so of saline solution that's up above. This is all on the inside. Patients often will ask, so the pump is on the outside so I can find it, right? And I'm like, no, if you see some of this hanging out of you, call me like immediately or actually come to my house and show it to me. Basically, to put the penis up, you'll squeeze the bottom part of the pump about 10, 15, 18 times. And it fills the implant with saline, gives a good, you know, rock hard erection. You'll leave that thing up for 10 minutes or 10 hours. So I always tell people that, you know, the upsides of this are good, firm, dependable erection, lasts as long as you want it, wherever you want. travels with you, will not set off metal detectors at the airport, will not get picked up by airport scanners. Although there's a caveat to that. About 3 weeks ago, I had a guy who called the office and said he got shaken down by the TSA because of his implant. Turns out the guy was walking around with it about 80% inflated. And so there was a bulge in his pants. It was not the implant itself. So I had to go over with him how to take it down properly to not get shaken down by the TSA. High satisfaction rates, patients, and I'm sorry, to take it down, if you see the little button on the front side, I'll teach you how to squeeze that and squeeze the penis and it comes right down. You should get it all the way down and walk around with a normal soft lip and penis. Better than 90% patient and partner satisfaction rates. Most common side effects, I always tell people, you're going to be bruised, you're going to be sore, you're going to probably hate me for 2 weeks. Biggest complaint I get is size. And so I'm very serious about talking to patients about size. I actually measure the penis, I stretch it out, I show them my ruler, I document how long it is. I always tell patients, I cannot restore your prior penis size. I can only preserve what we have when we do the surgery. I'll put the biggest implant in that I can fit. It's not uncommon for patients to lose a solid inch, maybe even a little bit more over what their penis was. But I always tell patients, look, you're going to trade a little bit of size for a whole lot of function. And so most people are very comfortable with that. Sensation is typically unchanged. Most guys can get to orgasm, 95% of guys, that is. Most guys that have these, 60% have had their prostate removed, so nothing is going to come out at orgasm because they don't have the prostate. But again, these are highly satisfactory. They typically will last about 10 or 12 years. They can be replaced. As you see at the bottom, at 7 years, 94% are still working. 10, 12 years out, if it goes down, springs a little leak in it, patient figures it out pretty quick because it doesn't go up at all. They give me a call, I check it out. Yep, it leaked. Let's replace it. Take the old one out, put a brand new one in, start over, have another 10 or 12 years. And some of them last longer, really depends on the use. If I've got a guy that's having sex 3 times a day, probably only going to last 5 or 6 years. If I've got a guy that is, pretty normal, once a week, probably going to get a good 10, 12, maybe 14 years out of it. Next slide. Different types of implants, 3-piece, which is what we just described, what's called the 2-piece or the ambicor. These are nice because if you're a little nervous to try to put the reservoir up top, like a guy's had bilateral hernia repairs, you can do a 2-piece. Honestly, I have done plenty of guys that have had hernias repaired. It's really not a big deal. It's really not that risky if you know what you're doing. The downside of the 2-piece is it only goes down to about 50 or 60%. They are hard as a rock. You give that pump about 3 pumps and it is stiff as a rock. But the thing is you can only take that 3 pumps out of it. I've actually only put 1 2-piece in my career. He had it for about 3 months and then requested a 3-piece, but he requested the 2-piece because he had bilateral hernia repairs, and I tried to tell him, and anyway. So that one that I put in is in a garbage can somewhere. And then a malleable implant, which is basically just putting 2 rods in. I don't do a whole lot of malleables. Malleable is really good for a guy that has something going on with his hands. I've actually got a guy on the schedule coming up for malleable, I think in the next month or 2. And he had a stroke. And so he doesn't have the use of half of his body. And so he's really nervous that he's not going to be able to figure out how to do the pump. And I told him, if you're happy with a malleable, we can leave it. If you're not happy, you can always go back and put in a 3-piece, and I can teach your wife how to pump it up and take it down, whatever works. So next. Oh, and then we don't have to go back to the next slide, but there are 2, AMS makes 2 different 3-pieces. They make the AMS 700 CX and the LGX. CX is controlled expansion. LGX is length girth expansion. I prefer the length girth expansion. Again, I direct you back to the length and size loss. And so I feel like it gives the best chance to gain back at least a little bit of the length, 1/4 inch, 1/2 inch. I teach my patients how to maximally inflate these, and we do that every day for 6 months in the postoperative period to try to get as much stretch as we possibly can. Most people 6 months later are much more satisfied with the size than immediately post-op. But let's see. AMS, it's the most used implant. I like the AMS for several reasons. Number one, I think the pump is much easier for the patients to learn and use. Number two, the tips of the implant are more rounded than the other companies. The other companies is very pointy. The entire implant is antibiotic impregnated and coated. That is actually slowly released over the course of about 2 weeks. So I believe that the infection rates would be a little lower. I think any high volume implanter, either implant is good for infections. I just think this is better. I think the reservoir is much nicer. It's much easier to place and much easier to conceal and hide. And then the big one is the location of the lockout valve. So in the AMS implant, the lockout valve is actually in the pump. And so essentially, autoinflation is non-existent. Once that thing is down, it's not going to go back up. The other company, their lockout valve is up on the end of the reservoir, and that actually can get kinked. And when a guy bends over to tie his shoes, it kinks it, squeezes the reservoir, and the penis goes up. In fact, about 10 years ago, I had a guy who had a different one put in over in Houston, and he was a limo driver. And he said, yeah, just sitting in his limo, it would auto-inflate, and he'd get out to let out like 16-year-old prom girls, and he'd have this erection. And he's like, you gotta do something about this, because at best I'm gonna get fired. At worst, I'm gonna go to like prison or something. So anyway, a whole lot of these have been put in, over 500,000. The first one was done about 45 years ago. Guy named Brantley Scott over in Houston was the go Texas, was the first guy to put one of these in. Unfortunately, he was killed in a plane crash, but that was a while ago. But he was a good mind. Of course, everybody thought he was totally insane for trying to do this. And then fast forward all these years, and there are awards in urology and prosthetic urology, like who's the most contributing prosthetic urologist. He gets the Brantley Scott Award for the year. So he's a very well-known name in urology. Unfortunate loss. Next slide. How does it work? We got a little video here. Simple enough. Squeeze the pump 12, 15 times. The fluid comes out of the reservoir, goes in the cylinders. Use it for as long as you want. Squeeze the down button. And I always teach patients that it will only come down about halfway. So what they should do is actually squeeze and push the penis in, and it will come all the way down. These are typically done as outpatient procedures. I do mine infrapubically. I make about a 1-inch incision right above the penis. They take me generally 30, 35 minutes to do. I send the patient out with a wrap on the penis and scrotum for compression and drain in. I see them the next day. I take the wrap off. I take the drain out. I leave the implant up about 80%. I take it down to about 30 or 40% on post-op day 1. Teach the patient the pump. I have them work with it for 2 weeks. I see them 2 weeks later, make sure they're healing. Go over the pump with them again. I see them at 6 weeks, make sure they've mastered the pump. I tell my patients, as long as they can put it up and take it down and they're physically comfortable, they can use it. So probably about half of my guys by the 6-week visit have used it, which is fine with me. At the 6-week visit, I teach them maximum inflation for expansion. I have them maximally inflated every day as hard as they possibly can. Try to have them overinflate it and leave it up for 15 minutes every day, whether or not they're using it. I see them at 6 months, make sure they're doing okay, and then I cut them loose at that point. So next. Private insurers, 50-50 on treatment of ED. Unfortunately, when I have a guy with Blue Cross in Texas, he comes in and we talk about an implant. I'm like, we'll try, but your Blue Cross does not cover these. 50% of the other private insurers. Medicare does cover implants, which is really nice. Incontinence is almost always covered by insurance or Medicare. That's it for that slide. Yeah, I've actually never had an incontinence procedure denied. Let's see. We got a couple of guys that had implants here. John, let's see. First time he'd ever had surgery. He was nervous. Recovery wasn't too bad. Having the implants, great. Got my life back. Prostate cancer, Cliff, not alone. I tell patients that I do this consult at least 10 times a day. I see 30 or 35 patients a day, and probably at least 10 of them are ED consults. So I try to make it lighthearted, the consult. I try to make them feel comfortable. Pretty much after patients walk out of my office after a 15 or 20-minute consult, they're very comfortable with what just went on, and they realize that I want them to have success with whatever they're going to do, essentially as bad as they do. So next slide. High satisfaction rates, like we talked about, above 90% for patients and partners. Again, insurance varies. Medicare does cover these, so that's nice. I've actually had a patient who I saw one time. He had just turned 61, and he wasn't able to pull it off for cash. Paying cash for them, everything included, they're about $20,000. Implant, anesthesia, surgery center, my charge, etc. And so this guy, on day one of his birthday month, when he was 65, he called the office. I hadn't seen him in 4 years. And he says, I just got Medicare. Can you put me on for an implant? And so I said, look, let me have you back in the office so I can examine you, make sure nothing of the physical exam has changed in 4 years. It had, and we put him on. Medicare paid for it, and he's happy. So long lasting, permanent, like I said, we typically get at least 10 or 12 years out of these. Again, I like the AMS implant because it appears more natural, both erect and flaccid. Should be able to get to ejaculation or orgasm. Again, if you don't have a prostate, nothing's going to come out, so no ejaculation. Spontaneous, like I said, wherever, whenever. You can be in a hot tub in Mexico when everybody else went inside for dinner, and you want to sneak one in, you can go ahead and do that if you'd like to. So it's nice. It puts the spontaneity back in. Next. Let's see. Risks involved with any surgery. Not all patients are candidates for penile implants. Honestly, the guys that I rule out are they just have other health problems that they just really shouldn't have anesthesia. Nice for spontaneity. Implants can fail, which can require revision surgery. Again, most of them will be good for 10 or 12 years. Pain, I tell my patients, yeah, afterwards, you're gonna hate me for 2 weeks. People with diabetes and spinal cord injuries are higher risk for infection, and I tell patients that I double my risk of infection. I quote about a 1% risk of infection overall. I tell diabetics that they're about 2% risk, so it's a double of the risk. It's still a tiny number, but still a tiny number, but it's much higher. So next. So in summary, this is common, ton of options. Implants are an option. We try to, we walk through the other things first. Whatever works for the patient, or whatever the patient's comfortable with, is what we stick with until it doesn't work. So I think that's about it. Whole lot of references there. Probably Dr. Brandt is probably, Brantley Scott is probably referenced in there somewhere. All right, questions. Let's see if I can open this chat box. Somebody said they're not getting audio. That's no fun. We did the whole thing without audio. I don't know what we can do for that. Let's see. Next question. How long should an erection last before ejaculation? Erection occurs on excitement, but lasts barely for a minute, so it causes a quick ejaculation. Is this considered ED or PE? If so, what are the options? Lab results came normal. Primary care mentioned Zoloft shows promising results to treat this. So yeah, it sounds like that's more of a premature ejaculation issue. So you're getting an erection, but you're getting to ejaculation too quickly. Premature ejaculation is defined as a ejaculatory period that is dissatisfactory to the patient or partner, okay? But what I will tell you that the average length of intercourse from penetration to ejaculation for humans is 4 minutes. Of course, young guys guess 2 hours, and I'm like, do you have a job? Like, don't you have anything else going on in your life? So it's 4 minutes. However, if somebody comes to me and their ejaculatory period it's 5 minutes, they're like, I ejaculate in 5 minutes, but that's dissatisfactory to me and my partner. What can we do? There's a whole lot of things that we can do. My first choice actually is a topical spray called Promescent. It's like a xylocaine spray. That actually is one of the best things. It's not terribly expensive. You can use 1 to 10 sprays. So you can either put a little bit on there on the head and the shaft, or you can soak the thing. You put it on. It's available online. You can get it at promescent.com. You can get it on Amazon or whatever. You put it on, rub it around, let it dry for a few minutes, and then you go for sex. That delays people. I tell people you can wear a condom, so that little bit of less sensitivity will help. Then we get into things like Zoloft. Another one that I use a lot of is called Cymbalta or duloxetine. And so those are antidepressant medications that have a side effect of delayed orgasm. And we can sometimes use that to our advantage. They can be used one of two ways. They can be used kind of like a Viagra a couple hours before, or the patient can take them on an ongoing basis every day. Normally, I tell people, try Promescent, try condoms, see how you like that stuff. We can add Zoloft, we can add Cymbalta. You can combine the Cymbalta and the Zoloft with something like a Promescent spray with condoms. I've only had one patient ever that nothing I did solve this premature ejaculation. I had him on drugs, I had him on sprays, I had him using condoms, and he's like, nope, still 30 seconds. I'm like, you're refractory, man. Like, I don't even know what else to do for you. So that's it. Next one, does the solution ever need to be changed or replaced? No, the only time it ever needs to be changed or replaced is if it leaks. And so, again, normally when one of these goes down, it will work one day, and then 3 days later, the patient, it won't go up. And so you can tell by hitting the pump that the pump won't re-expand because there's no fluid there. And so there's been a leak somewhere in the system. And so you replace the entire implant. You replace all parts, new solution, new pump, new reservoir, new cylinders. But no, it just cycles back and forth, and it stays contained. Let's see, next, thanks for your time, very informative. I'm a urology, awesome patients. Symptoms are relatively mild now. We'll consult with you should things decline. Anytime, my man. Any other questions? Got 20-something guys. I'm sure we have questions. Happy to answer anything. You're not going to make me blush. So next one is, what did you say the cost of an implant is? If the patient is not insured, so if they have no insurance, or like I said, Blue Cross does not cover them very well, everything included, anesthesia, surgery center, implant itself, these are pretty expensive implants. You obviously don't want this thing just falling off an assembly line. Each implant, I believe, takes 2 weeks to make. It's a 2-week process to make a single implant. Obviously, they're making more than one at a time, but they're not just falling off an assembly line. And so anesthesia, surgery center, implant, and my charge. Actually, I looked at one today, and it was going to be $21,500 was the total for everything. So that's everything included. Hope that helps. Hopefully you have coverage. These actually can be financed as well. There are financing companies for, quote, cosmetic surgeries like Care Credit, and there's a few others that will do fairly low interest loans for 3 years or whatever, et cetera. I don't do a ton of cash pay implants. I probably do 5 a year. I do about 100 a year. The other 95% are covered. Let's see, got one here. All right, so I got one comment. My prostate was removed by Da Vinci robotic surgery. And that's it. My comment on robotic surgery, the ED and incontinence rates honestly are very similar between open and robotic. The major advantage of robotics is the convalescence. The patients typically will either go home the same day or the next day with a catheter, whereas when we were doing these open, patients were in the hospital for 3 to 5 days. The blood loss was astronomical, et cetera. Next one is there a relationship between enlarged prostate or BPH and ED? Yeah, it's interesting. They commonly go together. There's 2 reasons for that. Number one, BPH can amplify ED symptoms, but more importantly, a guy who's old enough to have BPH is probably likely to also have ED. But interestingly, if you can help a guy with his enlarged prostate symptoms, oftentimes his ED will improve. Not a huge amount, but maybe by 20%. And often I'll have patients that will say, now that you put me on some alfuzosin, or now that you fixed my prostate surgically and I'm peeing, my erections, I went from having to use pretty hefty doses of Viagra to almost using it, for recreational purposes. I don't recommend, getting on BPH medications to treat your ED, but no, there is a relationship. I'd say that at least half of the relationship is the age of the patient, the age category that has BPH symptoms and ED, they're basically one and the same. Guys 50s, 60s, 70s, they tend to have both. Next one, are you familiar with Giddy, the ring at the base of the penis? Yes, it's the most expensive cock ring on the planet. There are, they beat me up all the time. Like, hey, when are you gonna get Giddy and start selling it in your office? And I'm like, when are we gonna stop charging $200 or $300 for a cock ring? They're nice. I think it's a good design. It probably should be about $30. There are inexpensive rings. I often, if I recommend a ring to people, I actually tell guys, get condoms and cut the tip off, and now you have a ring. Those are 50 cents a piece and they're disposable. I think if you got $200 or $300, Giddy's a nice ring. It's the Cadillac or the Lexus of rings, but let's see. Does that mean my vascular, this is back to the Da Vinci. Does that mean my vascular bundle was spared? It depends on the situation. If we have a biopsy or an MRI that shows that there might be extension of the prostate cancer on the left or the right, the surgeon will actually sacrifice the bundle on one side and spare the other side. In general, the majority of prostatectomies are done as fully nerve sparing, especially with Da Vinci. The other nice thing about Da Vinci is the dissection is magnified, and so you can actually see the layers better. And so you have a better chance of dropping those nerves away. Again, though, I'll tell you that the ED rates and incontinence rates, in my opinion, as the guy that fixes all this stuff, they're exactly the same. But the standard of care is Da Vinci. The patients do better. There's a whole lot less other complications, et cetera. With a penile implant, will your partner feel warm penis or will it be cold? No, it would be warm. You still have blood flow in the penis itself. You still have blood flow to the head itself through the urethra. And so no, it actually feels pretty natural. And in fact, most guys will get their head will still inflate because of the stimulation. That's coming through the urethra. Next one, Trimix can cause excessively long erections if the dose is off. I know there's another injection drug that will cause the penis to release the hold and relax. Is it possible to get a prescription with a supply of the relaxing injection just in case? It is really a problem to go to the emergency room, both for cost and embarrassment, plus removing blood from the penis is not what I like to see. So the truth of the matter is that, so when I teach a guy to do Trimix, I will actually use Trimix in the office. I will show the patient how to do it, go through the whole thing, cleaning off the penis, stretching it out, injecting the penis. That gives me, number one, now they know how to do it. Number two, the test dose that I use, I see how the patient responds to it in my office. And therefore, I know exactly, or I can come up with a very close estimate of how potent I should make it for him. I then tell the patient, now, when you get this, you're going to start off with a teeny tiny amount of this. We're talking about what I call 5 units on an insulin syringe, which is a 20th of a milliliter. And I say, look, you're looking for about a 30-minute long erection. If that's good enough for penetration. If 5 is not good, don't do it again the same day. But the next try, you're going to go to 8. And then the next try, you're going to go to 10, 12, 15. Tiny little baby steps to get to where you need to be. So I will tell you that most of my patients with those instructions and that demonstration, it is incredibly rare for one of my patients to end up in the ER. I know a lot of urologists, they'll just be like, hey, you should try this Trimix, and they'll write them a prescription and say, go to town. Those are the guys that end up in the ER because they draw up, they read the directions on thing. It says, okay, 0.05 to 0.5 milliliters. All right, well, sounds like I can use a half a milliliter. Says it on the container right there, should be fine. Draw up a half a milliliter, boom, priapism, they're in the ER. Because it wasn't explained 0.05 to 0.5, but it's a baby step thing. They just read it and they're like, all right, well, 0.5 should be safe. So it's super important to demonstrate to the patients, test dose them, see what it looks like, prescribe an appropriate concentration for that patient. Next one, when should a penile ultrasound be ordered by a urologist? In my opinion, if a patient comes to see me with a complaint of erectile dysfunction, I get a penile Doppler ultrasound. Gives a ton of information, helps me guide the patient down what's right for him. Should shockwaves be done? Are shockwaves an option or not? Do a ton of penile ultrasounds. I probably do 10 or 12 a week. I tell patients that only about 40% of the patients that I get ultrasounds on, and I interpret all of them, everyone that's ordered in the entire practice, I interpret and make recommendations on. Only about 40% are reasonable candidates for shockwave. The other 60%, I tell them, save your money. Shockwaves are not covered by insurance. It's $2,500 for 6 treatments. So I prefer to be dang sure that it's going to work reasonably well. I'd rather go a different direction for them. So for me, I get a penile Doppler on almost everybody that has an ED complaint. It's an inexpensive study. It's normally covered by insurance, certainly covered by Medicare. Gives us a ton of information. In fact, I've had occasion to do quite a number of follow-ups after shockwaves because the patients are interested to see how much their arterial flow improved. And the results are actually pretty impressive, better than I thought they would be. How about that? Let's see. Does erection in the morning need to happen always? If it does not happen, is it a symptom of ED? Well, morning erections will decrease with age. Guys will actually get between 10 and 15 erections a night. What you and I perceive as a morning erection is we just happen to be having one when we woke up. But as people age, their number of nighttime erections or nocturnal erections go down. And so the number of times that you wake up and have an erection is going to go down. If you remember when you were 18 or 20, you woke up with one like every morning. I'm almost 50. I wake up with one sometimes not. So yeah, it's a little bit of a sign of ED, but it's not exclusionary, meaning that I've got plenty of patients that tell me they only wake up once a week in the morning with an erection. And I say, well, what about when it's sex time? And they're like, oh no, if I'm stimulated, it's fine. So, it's the beginning, sort of, but not necessarily 100% correlated. Let's see, next, my prostate was removed 3.5 years ago. I tried Trimix injection, ended up in ER with priapism. Then I used Trimix gel as well as Cialis, but not an erection. Is it time to consider an implant? For that gentleman, sounds like you were not taught how to do the Trimix properly. So I would tell you that 2 options at this point. Number one, I'd probably do a penile Doppler ultrasound on you. Maybe yes, maybe no. Or I would re-demonstrate trimix and try it at an appropriate concentration and with appropriate approach to it. And if you're not happy with that, then it's kind of time to consider a penile implant. I'll tell you that post-prostatectomy, your erectile function can improve for up to about 2 years. Once you hit about the 2-year mark, it's probably about as good as it's going to get. And so that leads me to the next part that I tell patients all the time. Nobody's ever died of erectile dysfunction. But for most of us guys, if we still have a heartbeat and we still can walk and talk and breathe, we probably want to have sex with our wives. That's kind of normal human nature. So, with that information, probably, consider repeating a demo of trimix versus a penile implant. Go from there. That's my answer to that. Although I did have a guy about 6 weeks ago who told me during our consults 6 times that it was a life or death situation that he gets his ED fixed. I kept trying to tell him we're going to fix it, but nobody's going to die here. Nobody's going to die. What's your feeling about whether there is significant benefit when Cialis is combined with trimix? It works well for me. I have no problem with people combining PDE5s and trimix. It's fine. A lot of guys will tell me I'll take some Cialis or Viagra and it fluffs it out and gives me a better target. I'm like, it's fine. Again, it's really just that feeling out of how much trimix is work and you don't want to work. You don't want to go overboard. So I'm fine with it. And I have plenty of patients that do that. The other thing that I've been doing a lot of recently, and fortunately or unfortunately, I read one of my partner's notes today. I've been doing a lot of daily Cialis with boosting it with Viagra. We've actually found that the combination works better than you would expect. You would think it would be 1 + 1 = 2, but it's actually more like 1 + 1 = 2.25 or 2.5. So it's almost like a turbocharge. And so I think I interpreted a penile Doppler on a guy from one of my partners today. And in the note, it said, strongly recommended not combining Viagra and Cialis to the patient, and he should stop doing this immediately. And meanwhile, I do it all day long. So they're fine. So anyway, combining those is fine. Second topic, I've been taking saw palmetto for years. Last night, I read that Flomax and saw palmetto are approximately equal in effectivity for urination issues. It depends on what you read. I think saw palmetto works really well for somebody with very mild BPH symptoms. And so if I've got a guy that's just got real mild stuff, I actually do recommend saw palmetto. There is a supplement that I recommend that's available through Theralogics. It's a company it's a vitamin company, and they make something called Prostate SR, and that's Serona repens. It's saw palmetto is what it is. And I've got plenty of guys that are on that, and they do fine. A guy that comes in and he's really struggling to void, and his post-void residual is 300 milliliters. Saw palmetto is probably not for him. I would actually think that Flomax actually works, I think, a little better. And so that guy, I would put him on once a day or twice a day Flomax, see him back a couple weeks later, see how he's doing. But yeah, I've got plenty of guys on saw palmetto. But I would actually say Flomax is probably a little bit better than saw palmetto. Where's my office? I go to 2 offices. I think we've got like 12 offices in our practice. I go to the one on Jollyville Road on Wednesdays and Thursdays, and I'm at my Round Rock office, which is on 620. We have 2 Round Rock offices. I go to the smaller one on 620. I'm there Mondays and I'm there Fridays, at least for now. One of us is maybe going to start playing golf every other Friday. Mm-hmm. Let's see. I don't remember when I got it. Is when I got an erection in the morning. I get erection for a short time during foreplay, but eventually it ends up with the PE quickly. So it's sort of an early sign of ED. Again, I think this is the same person that asked about the PE. It sounds like PE, pretty much pure PE, premature ejaculation. And so I would want to try to, fix the premature ejaculation. Now, premature ejaculation sometimes can be the result of ED because the patient is trying so hard to keep his erection that he's going really, really fast, and then it ends in 60 seconds. And so that would be a slightly different situation where I'd say, okay, well, your PE might be the result of some ED because you're trying to go quickly to maintain the erection. And so that guy would work on his ED, see what happens with his PE, and then treat the PE later. So no, I wouldn't say that PE is an early sign of erection unless that patient told me, yeah, I'm trying desperately to keep it, so I'm going really fast, and therefore I have PE. Let's see, I recommend the Osbon penis rings, not too expensive, and has a loop to allow ejaculation. It does have a little niche in there to flow at least a little bit. You can buy online. Erectile pumps as well. So yeah, Osbon and Erectile, you can actually just buy the rings. I think they're like $10 or $20. They're not 200 or 300, and those are fine. They're reusable. You just wash them with soap and water, let them dry. There he said 21 bucks, so I was close. And yeah, I think they have little handles on them, so you can kind of stretch them and everything. Yeah, those are good. So you can just, you can get a ring like that from, really one of the vacuum erection device companies. And like he said here, Osbon is one. I think it's OSBON. It might be OSBORNE, or Erectaid, ERECAID. And yeah, 20 bucks, 21 bucks. Yeah, or a condom. Giddy if you just have 200 or 300 bucks laying around just roasting a hole in your pocket. Anybody else? I don't even know what time it is. Oh, 7:30. Yeah. So this comment is, for me, the pumps have a nice side effect. They make my girth increase. Yeah, that's true. The pump, I mean, you're going to get length expansion. You're going to get that girth expansion. And, for most guys, they do say with a vacuum pump, their girth is better than it was with a natural erection. Pretty common that you see that. So that's good. And yeah, if you you're one of the guys, sounds like you're one of the guys that uses a vacuum pump, loves it, and you're probably going to use it forever, so that's great. Let's see. Next is, do we need a referral to you from our primary care physician? That just depends on your insurance. So patients with like an HMO, they do require referrals. I don't think that Medicare patients do. Private patients with PPO, they do not either. If you normally have to get a referral from your primary physician to see any kind of specialist like a cardiologist or an ENT or something like that, then you would. I'd say that probably only about a quarter of patients still require referrals now. Seems like maybe a third. But if you've ever been referred to another specialist like a cardiologist, ENT, orthopedic surgeon, and it required a referral, then you should. I think our office, if you were to call our office, they would be able to tell you whether or not you need a referral. And yeah, I'm always accepting new patients. That's the next question. Are you accepting new patients? The answer is yes. Yeah, I'm always taking new patients. Happy to see anytime. Sometimes my office will tell you it's a couple-month wait. They might offer my PA, Sean Ormsberg, who's lights out awesome. He's like a second version of me. He's a lot bigger than me. I always tell him I'm better looking now. But yeah, we both do a ton of this, and so we can get people started down the pathway. Go from there. Anybody else? Oh, let's see. Creams as PD5. So sounds like you're asking me, is there a topical PDE5 cream? So like a topical Viagra or a topical Cialis. I've read about those. I don't think that the absorption is going to be high enough that it would do a whole lot. So I don't really prescribe those much. Normally the PDE5s are just pill form. Trimix is injectable. They do make a Trimix gel that you can shoot down the urethra. Trimix, I didn't mention this, but it's a combination of 3 vasodilators. So it's prostaglandin E1, papaverine, and phentolamine. They just go to the arteries, dilate the arteries like crazy, flow. But yeah, I don't use a whole lot of topical PDE5 inhibitors. Anyone else? Or is everybody wanting to go watch basketball? Let's see. Also, any natural ways of treating PE? Okay, so we talked about, promescent spray. We talked about condom use. We talked about SSRIs that are antidepressants that have side effects. I have read about things like, squeeze technique is one. So what squeeze technique is when you're having sex, right when you first get that little tingle, stop, pull the penis out, squeeze the head of the penis, squeeze the blood out of it, put it back in, start going again, tingle again, stop, squeeze the head, put it back in, go back and forth with that. That's called squeeze technique. I've read about training programs. I think that's more of a sheet that people hand their patients to get them out of their office, where you're supposed to have sex, stop when you're about to climax, count to 60, let it go down a little bit, start again. And they say, if you do that the next 10 times you have sex with your wife, you'll be cured. It's hard to train that. It's a nerve thing, and it's a hypersensitivity thing. But the one natural way that I recommend is squeeze technique, like I just described. It works, depending on how long you want to go. You might have to do it, 5, 6, 8, 10 times. But it definitely works. It definitely pulls you back from it. So little first tingle, pull it out, squeeze the head, wait a second, put it back in. See how that goes. Thank you for your presentation. Good info and explanations. Thanks for your time and info, Dr. Kansas. Sounds like everybody wants to go watch basketball. I'm with you guys. Maybe I'll win my pool this year. Probably not, but maybe. All right. Well, hey, thanks for attending. It was fun. Great questions. We covered a lot today. Happy to see you guys anytime. If you're already a patient in the practice, it's that much easier to get in with me just because you're established. We can just flip you over, etc. But anyway, I hope you guys have a good night. And again, thanks for your time, and really appreciate you guys attending. Thanks.